Good morning, everyone. I'm Dr. Vani Ravikumar from Metropolis, Bangalore. Welcome to the MedTalk, which is an initiative by Metropolis to engage with the various clinical specialties and the key opinion leaders. The topic for today is cancer in women. It is a very relevant topic for the present days since we are seeing many women afflicted by cancer. We have today a leading medical oncologist here with us on the forum who will be telling us more about this topic, enlighten us, and also share his knowledge as well as his vast experience with us. It is my privilege to introduce Dr. Radhesham sir. Dr. Radhesham Naik is the head of medical oncology, hemato-oncology and BMT at HCG Hospital, Bangalore, and also at Samprada Hospital, Bangalore. He is also on the medical advisory board for Oncomet at Metropolis. I extend a warm welcome, sir, and we shall start right away. My first question on today's topic, sir. As we all know, cancer can affect any part of the human body. There may be some which are more common than the others. First of all, can you name the top few prevalent cancers in women?
Thanks, Dr. Vani, and I want to thank Metropolis Lab for giving me this opportunity. I'm a medical oncologist, and to answer your question, women get a lot of cancers which men also get many times. But there are some cancers which are almost exclusively feminine. And the commonest is breast cancer and the gynecological cancers. And breast cancer is, of course, increasing exponentially now in our society, especially in the cities, urban areas. And in gynecological cancers, we have got CS cervix as the commonest. And in the rural areas, gynec cancer, cervix cancer is the number one. Still, it is more than the breast cancer. Though in urban areas, breast cancer has overtaken the cervix cancer. Then we see, less occasionally, we see the endometrial cancer, ovarian cancer, and of course, vulval, vaginal cancers and other things. Having said this, head and neck cancers also is very, very common among women in the rural areas. I think you are on the mute.
Okay. So the next question, sir. What are the predisposing factors and the risk factors for cancer in women? Please enlighten us about the predisposing factors and the risk factors.
Okay. If you start with breast cancer, which is the number one cancer in the women right now, we do not know exact etiological factor for the breast cancer. But we know the risk factors. What are the common factors in women who develop breast cancer? And the most common factor there will be the obesity. We get more cancers in women who smoke and have alcohol, and who have limited physical exercise, who are nulliparous, that means have no children, or who have a child after the age of 30. And some of these, and the people who have got, most importantly, familial risk factors, BRCA mutations in the family, BRCA1, BRCA2, and there are other genetic variations which can produce familial cancers. So familial cancers will be about 10% of all these cancers, whereas 90% will be environmental. What exact etiology produces breast cancer is unfortunately still not known. Coming to the cancer of the cervix, uterine cervix, which is again a very, very common problem in India, though the incidence in Western countries is rapidly going down or almost non-existent. It is related to HPV infection, and this is a DNA virus which infects the genital organs, and which over periods about 20 to 30 years later can produce cancer of the cervix. And the same virus can produce cancer of the vulva, vagina, and even anal canal, and sometimes posterior pharyngeal cancers also can be related to this HPV infection. CA endometrium and ovarian cancers, again, the mutations, BRCA mutation can produce the ovarian cancers. Tar powder is implicated many times in these cancers, and usually in the older women. So as you age, you can get some of these cancers. Exposure to multiple exposure to estrogens, combination pills, and other estrogen mimicking agents. Sometimes it is said that the plastics in the environment has an estrogenic effect. And many of these obese women will have more estrogens in the body. All other hormones are converted into estrogens. And so these estrogenic influences also can produce increased incidence of endometrial cancer. So these are the usual risk factors and etiological factors in women.
So, the next question, sir. Nowadays, we hear a lot of terminologies like diagnostic test, theranostic test, prognostic test, and screening tests. So these terminologies, they are a little bit confusing. Can you please explain these different terminologies and the different tests?
Okay. So whenever we see a woman, let us say, with suspicion of cancer, often the first test we do will be a radiological test, imaging test, because we want to know where it is and whether it has gone to any other organ. And also we want to make sure that we do the biopsy from an appropriate site. For that, imaging will be useful. Earlier era, I remember we used to just do with X-rays and ultrasound, and then we used to do the biopsy on that itself. And later, we started doing the CT scans, MRIs, and now majority of the cancer patients, even on suspicion, will have a PET scan, because PET scan shows the whole body, and we know all the areas where the cancer has spread, if it has spread. And also we will know the SUV, and the metabolic rate of the cancer, the rate at which it takes up the glucose in FDG scan, so which gives us a lot of extra information. So these are the imaging investigations we do. Even after doing the PET scan, we also do the MRI, especially if you are contemplating surgery of a particular organ, because it gives much more information about the soft tissue involvement, the plane in which the cancer is infiltrating, about the lymph nodes and all that. After the imaging, we of course do the biopsy, and which will be the most important diagnostic test in cancer. And once we establish a diagnosis of cancer, then we can send this tissue for a variety of tests, which depends on what cancer we are dealing with. For example, if it is breast cancer, we mostly look at hormone receptors, estrogen receptor, progestin receptor, androgen receptors. We also look at K67 to know how fast the tumor is growing. This is a mitotic index. And in special situations, we do other tests like we do HER2, we do the BRCA testing, and there are no next generation sequencing available, and 500 genes, 2000 genes analysis and all that can be done in these patients. Increasingly, we are using immunotherapy, so we do the test for PD-L1 and the tumor mutation burden to see whether patients need to be given immunotherapy or any other targeted treatment. These are the special tests we do, and most of these cancer patients nowadays, genomics is done almost upfront in majority of the patients.
Okay. The next, regarding the screening tests, sir, can you highlight regarding screening tests for cancer?
Yeah. So screening is an important aspect because even when you treat the cancer successfully, even if you cure a patient, you do it at great cost. Financial cost, of course, is well known, but there can be an organ loss, there can be physical and mental trauma, and the family also, along with the patient, undergoes a lot of stress during this period. So the best thing in cancer, the best way to deal with cancer is to prevent cancer. So we have what we call as primary prevention, which is where you change the lifestyle of the patient, like they stop smoking, reduce their weight, avoid obesity, right diet, etc., etc. Vaccination and all that come in that category. But secondary prevention is what we call routinely as screening. Screening is the method by which we can detect cancer at a very early stage, or even better, in a pre-malignant condition. We diagnose a pre-malignant condition. And we utilize that in breast cancer, for example. We teach the patient breast self-examination, where every month they can look at their breast, palpate, and if there is any suspicious lesions, they can come back to the doctor. Second thing is we do the mammogram in high-risk individuals, especially after the age of 50. Though in India, we should start at 10 years before, at the age of 40, because we get a lot of cancers in the age group of 40, unlike Western countries. And for the cervix, we do the pap smear, speculum examination, and to prevent it primarily, we can do the HPV vaccination, which prevents HPV infection, and in turn it can reduce all the cancers related to HPV vaccination. For the other cancers, it is very difficult. For example, ovarian cancer, it is, for example, if you take a combination pill, where estrogen progestin combination pill, they have seen that 50% of the ovarian cancers can be prevented. But on the other hand, this combination pill can increase the chance of breast cancer. It can increase the chances of endometrial cancer. So we have to be careful about utilizing certain things which can complicate and result in some other cancer. I think these are the general things in female cancers which can be tried out.
Okay. So to just summarize that, we have the self-breast examination, mammogram, then the pap smear testing. These are some of the important screening methods available. Screening, of course, it is not available for each and every cancer. It is available only for a few type of cancers only, like this breast cancer and cervical cancer. So it is better to take the precautions and avoid those predisposing factors and the risk factors. Now, my next question is that what we are hearing nowadays, that the incidence of cancer is arising in a much younger individuals, and that is becoming more common compared to the past decades, where cancer was always seen in the older individuals. Nowadays, many cancers we are seeing in the young people, and that is on the rise now. Is it true that are you seeing these younger individuals getting more incidence of cancer? And what do you think is the cause for cancers arising at younger age? What factors are contributing to this early age onset of cancer? And does genetic makeup also contribute to this getting early age cancers?
Yeah. Our own experience also, though there is data also, our own experience also in practice over the last 30 years tells us that the cancers in young people is increasing. And we think that there are three important factors why that is happening. Number one, of course, is the extensive availability of imaging services, lab tests, diagnostics, genomics, and all that. So at least certain percentage of patients who are not getting diagnosed earlier, I think, are getting diagnosed very early. For example, if you are catching the diagnosis at the age of 40, maybe 5 years before only by the methods which we have, we may catch the patient. So that may be one of the reasons. The second reason, of course, is the rapid adoption of Western lifestyle. I think increasing smoking, increasing obesity, and wrong diet, of course, which is fast food and unhealthy food, no cooking at home and eating outside always. I think these are the issues. Increased intake of alcohol and increased incidence of obesity in our people. And some of the cancers are related to, again, marriage. Age of marriage is being extended to about 30 now. Having children, having less children, 1 or 2 now, instead of what used to be earlier 4 or 5 children. Late pregnancy, and extensive usage of some of these drugs, including estrogens and progestins and all that. And we also saw that in villages we are getting patients who have none of these standard risk factors. To give an example, we say that obese patients eating fast food and not exercising are getting, and who have less children and all that. We also see in rural women who have multiple pregnancies, who breastfed all their babies, getting cancers. So we feel that there is also environmental pollution, insecticides, pesticides, plastics, and poor ventilation at home, for example, what we call as indoor pollution. All these are giving now more and more kind of cancers, increasing younger women. And one more important thing is a lot of these young women now have started smoking and taking alcohol in large quantities, which was not the case earlier. And this probably has increased cancers like lung cancer. When I started my practice, I never used to see, very rarely used to see a woman with lung cancer. Now, almost 40% of our lung cancers are women. It's probably happening because of the smoking. And the second big challenge India is facing is teen smoking. People have started smoking at a very early stage. And second problem is female smoking, which has exponentially increased. So these two are now, I think, causing an explosion of cancer in young individuals. Now, it is very important that this problem has to be tackled, because younger individuals, when they get the older cancers, like colon cancer, breast cancer, lung cancer, their prognosis is usually worse than the older people getting cancer. So that is the reason why we need to really focus on these young cancers.
It is rather alarming to hear that even lung cancer is increasing at such an exponential manner, even in women, because of
we also are seeing now in our OPDs lung cancers, colon cancers, and all that at the age of 14, 15, 16 and all. We will never used to see patients like that. We many times think that it's some other thing, and then when we biopsy, we are shocked to see that lung cancer at the age of 14 and breast cancer at the age of 16. One day we saw a boy, 13 years old, 12 years old, who had colon cancer. So we are seeing this kind of thing prominently.
Okay. So the next, I would like to know what are your recommendations for routine tests, like the blood test or the urine test or the radiological tests like the scans, X-rays, MRI, PET scans. So any recommendations for routine testing by a woman which she has to undergo to detect cancer, and at what age do you recommend that these tests be performed for a woman?
Okay. See, ideally, we should have the screening of the whole body, because anybody can get any cancer. It is not necessary that women have to develop only breast and cervix cancer. They can develop lung cancer, for example. They can get oral cancer. They can develop colon cancer. We see a lot of that. So right now, according to the WHO recommendation, an ideal screening test is not available. What we do instead is we have specific areas or specific cancers only. For example, breast cancer. For lung cancer, a CT scan, especially if you are a heavy smoker. For cervix cancer, we do the pap smear and HPV DNA. And for colon cancer, we do the stool occult blood examination and colonoscopy in high-risk individuals. These kinds of things are done. But in our hospitals now, we are trying to innovate, because we know that these tests are not good enough. We diagnose patients at a late stage because of these tests are not sensitive enough, and the only a few organs are protected. So what we suggest is, what we are doing at least in HCG and Samprada is a patient of high risk, we do the whole body MRI, which will tell us whether there is already existing radiologically visible cancer or is there or not. And then we do in highly suspected individuals extra tests like gastroscopy, colonoscopy, PSA levels for men for prostate cancer, pap smear for women, HPV DNA, and of course mammogram and all that. We don't know how far this is feasible. We have bundled everything and maybe making it at around 25,000 rupees or something like that. But many people may not be able to afford this. Many people may not be willing to undergo also this. So it is a difficult job. It's also not only in India, even abroad, I think it is not uniformly successful to screen people.
Okay, so screening for cancer by performing these routine tests, it involves a lot of cost plus the availability also. So it doesn't really, cater to the general public at large, except maybe simple tests like a self-breast examination and a simple pap smear. So these look more feasible as a screening test and a routine test to be done by the women. So my next question would be, overall, do you think that the incidence of cancer in women is showing an upward trend, or Do you think that since there has been so many advances in laboratory diagnostic testing and detection modalities available, do you think that there has been a decline in the incidence of cancer incidence, or is it still showing an upward trend?
Yeah, most of the cancers, the total cancer incidence is going up. There is no doubt at all about that. Maybe because of combination of people living longer, and because cancer is a disease of the old age, because of changing lifestyle, and the third is better detection. Because of all these reasons, the total cancer incidence is definitely going up. But some cancers, it is not uniform. There are some cancers which are going down, some cancers are going up. If you take an example of lung cancer, when I was doing my fellowship in oncology, squamous cell carcinoma and small cell lung cancers were the common things, and adenocarcinoma was not that common. So now most of our patients, 70%, 75% of the lung cancers now are the adenocarcinomas. And most of this is related to women smoking, because they use only the filters, long filter cigarettes, and even men smoking less, but over a prolonged period. So there is a change in the histology of the cancer. Like that, for example, stomach cancer, we are seeing that the distal stomach cancers are coming down, pyloric cancers, and esophageogastric cancers incidence is going up. And we are seeing that anal cancers are almost disappearing. We are not seeing at all in our hospitals. Anal cancer, which we used to see as a student, I used to see 2, 3 in every OPD. We are not seeing even one now in a year. But colon cancer is increasing. And rectal cancers are coming down, and proximal colon cancers are increasing. Lymphomas are increasing. In women, lung cancers are disproportionately more increasing. And when I was a student, the cervix cancer was the predominant cancer. Maybe if you see 5 cervix cancers, we used to see 1 breast cancer. Now I think we are seeing 5 breast cancers, we are seeing 1 cervix cancer, at least in Bangalore. So the incidence of cervical cancer is coming down. Breast cancer is disproportionately going up. So there is a changing epidemiology of cancer, which is very, very evident, at least in urban areas. Maybe because of westernization of the culture.
Okay. So that is that was an interesting point to note. So next, we are now in this era of precision medicine, personalized medicine. Can you talk about molecular testing in cancers? What molecular tests are currently being done at the labs, and how are these molecular tests helping you clinicians in treatment and management of cancers?
Okay. Just to take an example, because this is only the cancer in the women, I will focus there, but some of these are more relevant in lung cancer and other colon cancer and all that. But just to take an example of breast cancer, I remember that we used to have only estrogen receptor positive cancers and estrogen receptor negative cancers. And we used to give chemotherapy to estrogen receptor negative breast cancers and hormone therapy to estrogen positive breast cancer. Now we group breast cancer into HER2 positive, ER positive. HER2 we do, that's another test on the breast specimen. We have triple negative breast cancers. In triple negative, we have got some 4 or 5 types. So totally, breast cancer is about now 10 different kinds of cancers, and we treat them differently. So this is one example of how routine IHC, immunohistochemistry, was changing. But now the genomic revolution which has happened. So we want to now fingerprint the tumor by looking at the genomic analysis. And this helps us in one is prognosticating the patient. For example, you have HER2 positive. those breast cancers don't do as well as ER positive breast cancer. Triple negative breast cancers do worse than the other breast cancers. So we have got this prognostication issues. The second thing will be new group of drugs. For example, immunotherapy. If PDL1 is positive, or if MSI is high, we use immunotherapy. Our tumor mutation burden, which we get from genomic testing, if it is high, then we can use immunotherapy for the patients, which is contrast to the chemotherapy, much less toxic, and stimulate the body immunity in turn, which can control the cancer. Like that, we have got newer agents like anti-angiogenic drugs. We have, if your BRCA is mutated, or if BRCA is mutated, we have got drugs like PARP inhibitors, which can be used in these cancers, and they have prolonged the survival. At least disease-free survival is prolonged in those cases. So instead of using only chemotherapy, radiotherapy, and surgery, which we had for decades now, we now have targeted treatments. In lung cancer, for example, we test every patient for EGFR mutation. If it is mutated, we have got tablets called tyrosine kinase inhibitors, which can block this and give prolonged survival. So patients who used to survive for 6 months now can survive for 5 to 6 years. So that kind of a treatment. You have got a mutation called ALK mutation. There are drugs which are suitable for ALK mutated patients and BRAF mutated patients. So now the lung cancer is sliced into different types of cancers, and by individualizing this treatment with genomic help of genomics, we are able to prolong survival in certain segment of these patients. So when you do not have any of this, we have PDL1, for example, we can use immunotherapy for those patients. So the treatment has changed now. What we used to do earlier was standardized trial-based treatments. Now we look at an individual patient, his characteristics, the tumor characteristics, and together with that, we say give the precision medicine, precision therapy, which will be suitable for that patient, may not be suitable for others. So that is, I think, a kind of a revolution in oncology treatment, which has cut down the toxicity and also to some extent cut down the cost indirect.
It's actually good to know that this kind of personalized treatment is definitely prolonging the survival rate. And of course, I think cost will be involved, but it is good to know that we do have these kind of treatments available. Now, coming to my last but one question. Next generation sequencing, NGS. This is quite a common term we hear nowadays, NGS. It is an upcoming technology for comprehensive genomic profiling and also to understand multiple molecular alterations. And can you please elaborate on this NGS and molecular profiling?
Yeah, this is one of the real big steps which have forward step, progressive steps which has happened in oncology. I remember that when say about 7-8 years back, when NGS came in, I think people were hesitating. People were thinking that it is not necessary to use these things, and even today, some resistance is there in using NGS. But I feel that compared to small panels, next generation sequencing can tell us the whole genomic profile in this patient. And there are targets, there can be targets in the tumor which may not be usually seen in that tumor. For example, in lung cancer, you can have some target which may not be usually, that treatment may not be used in lung cancer. And we have seen so many such cases. We use the drugs which we use for some other tumor for this tumor. And we have got good results. So instead of treating only on the histology, that means lung cancer from lung primary, we should treat on the genomic profile of the tumor, whether HER2 is positive or not, ER positive or not, whether BRCA is mutated or not, KRAS is mutated or not. So depending on these targets, if you treat, then you will get the best of the results, and you will not be having a toxicity of a treatment which did not be given actually, if you have the genomic profile. The second important thing this NGS has done is sequential NGS testing. Because if you do it once, it may not be the best method. If we give one treatment, if patient develops resistance to that and the cancer starts growing again, we do another NGS and we know, okay, the targets have changed and we modify our treatment. So instead of continuing the futile treatment of its cost, its side effects, you can target the correct treatment for. Now there are in patients with us now who have had 4 or 5 NGS done during the course of their treatment, and they got the most rational targeted treatments and had the best quality of life and prolongation of survival. The problem, of course, is still NGS is a little bit expensive, and we need to evolve ways of reducing that cost. I think you are on mute.
Yeah. Hopefully, let us look forward to the future where the cost of NGS will come down, considering that a patient with cancer will undergo several times the NGS testing. Hopefully, let us hope that the cost will come down and it becomes more affordable. So my last question, sir, I think you have already touched upon the PD-L1 and immunotherapy, etc. So generally, people have heard of radiotherapy, chemotherapy, but immunotherapy is something, the public, it's a relatively new word. So can you please describe immunotherapy?
Okay. See, usually if you look at the tumor, if you see it in a section, you see the cancer cells, but there are a lot of normal cells around them, and we call that as tumor microenvironment. So there are a lot of cells which are neutrophils, macrophages, there are lymphocytes and all that. And many of these tumors have a lot of these immune cells surrounding the cancer cells. The question always is why the cancer is increasing though the immunity is trying to act against cancer. And the research showed that the tumor produces PD-L1, which is a surface protein, and covers itself with PD-L1, which blocks the action of the lymphocytes. It causes energy of the lymphocytes. They won't get activated. They won't act against the cancer cell. So what the scientists have done is which can come and block this PD-L1 and so can activate the lymphocytes. So lymphocytes get activated. So these lymphocytes in turn will kill the cancer. So it's an indirect effect. So you stimulate the body immunity, you energize the lymphocytes, and lymphocytes kill the cancer. And because of this effect, the adverse events are very, very less with immunotherapy. Even very old people. We have used immunotherapy in patients who are even 95 years old. Our oldest patient is 95 years old. Even patients who have poor performance status, whom we cannot give chemotherapy, also will be eligible to receive the immunotherapy. Now, this immunotherapy is available in the market. There are 5 different antibodies manufactured by different pharma companies available, and we put them into the normal saline bottles and run over a few hours. These drugs go into the tumor microenvironment, take out the PD-L1 because it blocks the PD-L1, activate the lymphocytes, and so cancer control is achieved. The only problem with this immunotherapy drug, one is the cost. It is costly treatment. One cycle of treatment may cost approximately 2 lakh Indian rupees. The second problem is it works in certain percentage of people, and it may not work in everybody in whom you use it. On an average, about 30% of cancer patients it may work. That is the second problem. And the third problem is it has to be given indefinitely. Since they are costly and it has to be indefinitely given, many patients, most of the patients I would say, will not be able to afford it after a certain period of time. And the fourth, a lesser problem is in some people, it can activate the autoimmunity because you are stimulating you're taking out the blockade. And this PD-L1 blockade is necessary for normal immunosuppression because you don't want autoimmunity. And sometimes these lymphocytes can act against your own body, produce autoimmune complications. This is a rare phenomenon, but it can happen.
That was an extremely interesting insight into immunotherapy. And I think with this, we have come to the end of our the discussion session. I will just go and check if any questions are there from the audience. Yeah, there are one or two questions. The first one is, sir, what is the impact of HPV vaccine on cervical cancer? Do you feel vaccines have a role in other cancers too?
Okay. Yeah. HPV vaccines can prevent most of the cervix cancers. Most, I say, because they cannot cover all the isotypes of HPV. So each vaccine has certain types which it can prevent. But 95% of the cervix cancers can be prevented if you are vaccinated at an young age, before the age of sexual activity. Because by that time HPV get in, and after that, as you age, the efficacy of HPV vaccination comes down. After the age of 25, it is much less. And after the age of 45, it is virtually useless. So if at all you have to get vaccinated, try to do it before 25 years. Even better at the age of puberty. But up to age of 45, some protection can be given by HPV vaccination. That is about the HPV. HPV not only is for the women, because in women it can protect against cervix cancer, vaginal cancer, vulval cancer, and to an extent anal cancer. So these are the cancers which it can prevent. And also it can prevent from the oropharyngeal cancer, oral cavity. It can prevent from these 5 cancers. In men also, it can prevent anal cancer, penile cancer, and oropharyngeal cancers. So ideally, HPV vaccination should be given both for boys and girls. Another reason why boys also need is usually they also transmit it to the girls. So it is better to vaccinate everybody, but because of the financial reasons, the government has taken the stand that they will vaccinate only the girls right now. But there is benefit in vaccinating boys also. Now, this is about the HPV vaccination. Coming to other vaccines which can prevent cancer, the only other vaccine which is known to prevent cancer is hepatitis B vaccination. This prevents maybe certain percentage of liver cancers from developing. Not all liver cancers, because there are several other reasons for liver cancer, including hepatitis C infection, then the syndromes of obesity, NASH syndrome, and all. So a lot of other reasons for the liver cancer. So these are the two vaccines which can help prevent two common cancers, cervix cancer and the hepatic cancer.
All right. We have one more question, sir. With increased hyperestrogenic states, we are seeing more cases of endometrial carcinomas. Does molecular classification of these tumors have a major clinical impact on the patient treatment?
Yeah, the most important important thing which has happened in endometrial cancer is one, increased usage of systemic treatment. We are increasingly seeing chemotherapy being used extensively even before surgery, after surgery, along with radiation, after radiation and all that. Second is increasing use of anti-estrogenic treatment in some of the cancers, some of these cancers, low-grade endometrial cancers. And the most important is extensive use of immunotherapy. 50% of the patients of endometrial cancer can have an immune profile which is conducive to use of immunotherapy. So many of the patients go for prolonged survival now with immunotherapy and chemotherapy combination, and sometimes only immunotherapy and anti-angiogenic treatment. And that has revolutionized. If there is one tumor which has been revolutionized by immunotherapy, one is melanoma, renal cell cancer, and of course, the endometrial cancer. I think revolutionized that therapy. And now endometrial cancer is being divided into several types depending on the immune environment and all that. And in some of the good immune environment tumors, we are avoiding extensive therapies. They are curable even without too much of treatment.
Okay. Last one question from my side, sir. For hormone receptor negative breast cancers, any newer modalities of treatment are available?
Yeah. For HER2 positive and ER negative patients, lot of anti-HER2 therapies are available. Trastuzumab, pertuzumab, TDM1, and all that. There are several, lapatinib. So there are about 6 different anti-HER2 treatments available there. That is that. And that has segment as now HER2 positive breast cancer patients are almost doing as well as estrogen receptor positive patients. It has come to that level. That's sophistication. But the triple negative breast cancers had bad prognosis. But now we have immunotherapy there, PD-L1 positive, triple negative breast cancers. We use immunotherapy, and that has given us some edge, some improvement in the survival. Now we have got AR positive, triple negative breast cancers, androgen receptors. So anti-androgens are being used in those tumors, and they do that much better than other triple negative breast cancers. And many of the triple negative breast cancers can be BRCA mutated. So PARP inhibitors are being used in this. They are tablets which block the PARP, and they can be effective in BRCA mutated breast cancer patients.
So one last question. One Divya has asked a question. How many days after the periods should we do the LBC and the HPV DNA testing? How many days after the menstrual cycle should we do it?
You can, I think, maybe a week later.
Yeah, I think so, because just to avoid the hemorrhage, avoid the blood RBCs, once the bleeding, the period stop, it can be done.
Yes, yes.
So I think with that, we have come to the end of this session, sir. And I'm extremely grateful to you for giving such a wonderful talk and such relevant information about cancer in women. And we are very grateful to you for your time, for sharing your experience and enlightening us with your vast knowledge. So thank you very much, sir.
It is my pleasure, and I thank you very much for for inviting me, you as well as Metropolis Lab. Thanks a lot. That's all.